Good evening, everyone. Today, our lecture about the fundamentals of intra-aortic balloon pump. These are our lecture outlines. We will talk about brief history about the history of intra-aortic balloon, the cardiac cycle, the coronary perfusion, the arterial wind castle effect, indication, contraindications of intra-aortic balloon therapy, device configuration, mechanism of action, the hemodynamic effect of intra-aortic balloon, and regular base assessment of the patient during intra-aortic balloon, troubleshooting and complication, weaning from the intra-aortic balloon, and removal of intra-aortic balloon. This lecture will be divided into three parts, and the first part will talk about the physiology behind the intra-aortic balloon. And the physiology behind intra-aortic balloon, we will talk about the cardiac cycle, the coronary perfusion, and the arterial wind castle effect. And the next part of the lecture will talk about the indication, contraindication of intra-aortic balloon therapy, the device configuration, mechanism of action, hemodynamic effect, and the patient assessment during intra-aortic balloon. And the last section of the lecture will be about the troubleshooting, complication, and weaning from the intra-aortic balloon and removal of intra-aortic balloon. So the intra-aortic balloon is the most commonly used mechanical circulatory support device that has been used for years in order to assist the failing heart in case of cardiogenic shock, especially in those patients with cardiogenic shock after acute myocardial infarction. The history of the intra-aortic balloon started in 1961 with the preliminary studies of intra-aortic balloon, and the concept of the external counterpulsation was introduced by Dennis et al. In 1963. And in 1967, it was the first clinical application of the successful intra-aortic balloon treatment. And in 1970, almost 30 patients with cardiogenic shock have been treated with intra-aortic balloon successfully. The first part of the lecture, as we said, it will be about the physiology behind the intra-aortic balloon. And the first part will be about the cardiac cycle. And as we know from the physiology that the cardiac cycle is divided into two parts, the electrical and the mechanical cardiac cycle. And as we see from this cartoon that both the electrical and mechanical cardiac cycles both are working simultaneously at the same time. And regarding the electrical cardiac cycle, it is divided into the electrical cardiac cycle for the atrial and the electrical cardiac cycle for the ventricles. And the electrical cardiac cycle for the atrial, it starts with the atrial systole in the ECG, which start at the mid of B wave till the peak of R wave. And after that, from the peak of R wave till the mid of the next P wave, it will be the atrial diastole. And regarding the electrical cardiac cycle of the ventricle, it starts with the peak of R wave, where the ventricle will start the ventricular systole till the late of T wave, where the ventricle will start the diastole till the next peak, the peak of the next R wave. This is the electrical cardiac cycle for the atria and the ventricles. And as we see from the cardiac cycle that the time for the atrial systole is very short compared to the time for the atrial diastole. And also the time for the electrical cardiac cycle for the ventricular systole is shorter than the time for the ventricular diastole. And the mechanical cycle is talking about the mechanical changes in the pressure and the volume inside the heart, mainly the left ventricle, during the systolic and the diastolic phase. And as we see here, the systolic phase is divided into two phases: the isovolumetric contraction phase and the ventricular ejection phase. After that, the diastole will start, which is formed of three phases. The first phase is the isovolumetric relaxation phase, then ventricular filling phase, and during the ventricular filling phase, the atrial will contract in order to assist the filling of the left ventricle during the diastole. And these are a diagram of the all the phases of the mechanical cardiac cycle. It starts with the isovolumetric contraction phase, then will be followed by ventricular ejection phase. After that, isovolumetric relaxation phase, ventricular passive filling, and atrial contraction. And these three phases are happening only during the diastole, and these two phases are happening during the systole. And this is the summary for the mechanical cardiac cycle. The systole is divided into two phases: short phase of isovolumetric contraction phase, and longer phase, which is the ejection systolic phase. And the diastole is divided into isovolumetric relaxation phase, which is very short phase, and the more prolonged phase is the diastolic filling phase. And as we know that the mechanical cardiac cycle is describing the changes in the pressure and volume inside the left ventricle throughout the cardiac cycle. So if we put the pressure changes and volume changes, so we can get this graph regarding the pressure changes inside the left ventricle throughout all phases of the cardiac cycle. And also we can have changes of the volume inside the left ventricle throughout the all phases of the cardiac cycle. And as we see here from this cartoon, that the cardiac cycle start here at this point, where the mitral valve will start the closure. After closure of the mitral valve, the isovolumetric contraction phase will start, and as you see, this is very short phase of the systole, and after that it will be followed by longer phase of the ejection of the blood, which is called ejection systolic phase here. And after that, the at this point the systole will finish, where the aortic valve will close, which will initiate the first phase of the diastole, which is a short phase. It's called isovolumetric relaxation phase. And after the end of the isovolumetric relaxation phase, the mitral valve will start opening, where the left ventricle will start filling of the blood to start the ventricular diastolic filling in order to fill the left ventricle with the blood. So the mechanical cardiac cycle starts with mitral valve closure, and this will initiate the phase of the isovolumetric contraction phase. After that, the aortic valve will open, where the left ventricle blood will be ejected to the aorta in the phase which is called the systolic ejection phase. After that, the aortic valve closure will lead to initiation of the isovolumetric relaxation phase of the diastole, which is a very short phase. After that, the mitral valve will start opening, which will lead to filling of the ventricle with the blood in the phase which is called the diastolic filling phase. And later on, the mitral valve will start a closure to start a new cycle. So going to the first part of the cardiac cycle, which is the isovolumetric contraction phase. It is called isovolumetric because in this phase there is no change in the volume inside the left ventricle, because in this phase what happened here is that the mitral valve will start closure, At the same time, the aortic valve is still closed. So here the mitral valve is closed, and here the aortic valve is closed. So the ventricle will start the contraction. The volume inside the left ventricle will be the same, but the pressure inside the left ventricle will be increased, simply because the valves are closed. So nothing going inside the left ventricle and nothing going outside the left ventricle. So when the ventricle will start the contraction, the volume inside the left ventricle will be the same, and the pressure inside the left ventricle, it will be increased. And as you see here, the isovolumetric contraction phase start with the peak of the R wave, which is a short wave from the peak of the R wave till the end of the QRS complex in the ECG. And after that, the left ventricle will start contraction, and because the contraction, the pressure inside the left ventricle, it will be increased. But as you see here, no change in the volume. The volume here is not increasing and not decreasing because both valves are closed. So with the contraction of the left ventricle, the pressure will be increased, reaching to this point, but the volume will be the same. That's why they are calling isovolumetric contraction phase. Then the next phase is that when the aortic valve start opening, at this point here, the aortic valve will start opening. With the contraction of the left ventricle and opening of the aortic valve, what will happen is that the volume inside the heart will be decreased because the blood inside the left ventricle will be directed to the aorta in order to perfuse the organs. So what happened in this phase, that the left ventricle continue to contract and the pressure inside the left ventricle will continue to increase, but the volume of the blood inside the left ventricle will be decreased because the blood will be ejected through the aortic valve into the aorta distal to the distal organs. And as you see here, because the left ventricle starts the contraction, the left ventricle pressure, it will be increased, reaching to the maximum here. And as you see the volume graph, you see here, the volume inside the left ventricle is decreasing, reaching to this point. So the pressure in the ejection systolic phase, it will reach to the maximum, which is the peak systolic pressure, and the volume inside the left ventricle during the systolic phase will reach to the minimum, which is the end systolic volume. So this is the end systolic volume. This is the volume inside the left ventricle at the end of the systole. And here, the pressure here, the maximum pressure here is the pressure, the peak systolic pressure at the ejection systolic phase. Going to the next phase, which is the isovolumetric relaxation phase. Here, after the ejection of the blood from the left ventricle, what will happen is that the aortic valve will start closure again. So the aortic valve will start closure again, and at the same time, the mitral valve is closed. So again, what will happen is that this is the diastolic phase. The left ventricle will start the relaxation, and the because the both valves are closed, and the left ventricle will start the relaxation. So there will be no change in the volume inside the left ventricle, but you will notice that the pressure inside the left ventricle will be decreased because of the relaxation of the left ventricle. So as you see here, the pressure in this phase will start to drop from this point till this point, and the volume will be the same in this phase because there is no change in the volume inside the left ventricle because both mitral and aortic valve are closed. So that's why they are calling isovolumetric relaxation phase. Isovolumetric, that means there is no change in the volume. And because it's relaxation phase, you will notice drop in the pressure inside the left ventricle in this phase. And at the end of the isovolumetric relaxation phase, what will happen is that the mitral valve will start the opening. And when the mitral valve will start the opening, the blood inside the left atrium will be directed to the left ventricle in order to fill the left ventricle with the blood during the diastolic phase. And this will happen during the diastolic filling phase, is that when the mitral valve will start opening, it'll start filling the left ventricle with the blood, and you will notice that the left ventricle volume, this is the volume inside the left ventricle, will be increased gradually till it reach to the maximum here, which is the end diastolic volume. So the volume here in this phase, at the end of the systolic phase, it's called end systolic volume. And the volume here at this point, at the end of the diastole, is called the end diastolic volume. And during the diastolic filling phase, there is almost no change in the pressure inside the left ventricle. So you will notice only increase in the left ventricle volume during the diastolic phase, but the pressure change, it will be minimum only. So this is the last phase of the cardiac cycle, which is the diastolic filling phase. And the diastolic filling phase is known to be the longest phase of the cardiac cycle. And during this diastolic filling phase, the coronary perfusion, almost 80 to 90% of the coronary perfusion is happening during this phase. And if we plotted the changes inside the left ventricle pressure against time throughout the cardiac cycle phases, you will get this graph of the left ventricle pressure time curve, and throughout the cardiac cycle. So this is the first phase of the cardiac cycle, which is the isovolumetric contraction phase. And the next phase is the ejection systolic phase. And the third phase, which is the isovolumetric relaxation phase. And the last phase is the diastolic filling phase. And as we see here, the pressure changes during the isovolumetric contraction phase. You will notice the aortic valve will start the mitral valve will start the closure here, and the left ventricle will start the contraction. So the pressure inside the left ventricle will increase till this point where the aortic valve here will start opening, and the pressure inside the left ventricle will continue to rise, reaching to the peak systolic pressure here. And at this point, the aortic valve will start the closure to start the isovolumetric relaxation phase, because the aortic valve is closed, and at the same time the mitral valve is closed, and the ventricle will start the relaxation. So you will notice drop in the pressure inside the left ventricle during the isovolumetric relaxation phase. And after that, the mitral valve will start the opening at the end of the isovolumetric relaxation phase, leading to initiation of the diastolic filling phase. So these are the changes of the pressure inside the left ventricle throughout the cardiac cycle. Is there any questions from your side? Hello?
No, it's clear so far, doctor.
Clear, huh?
Yes, doctor, it's clear.
Okay, anyone in the waiting room? So everyone is attending.
Some
Okay.
people are facing difficulty to join the meetings.
Difficulty to join?
Yes.
But no one is pending. Only 13 people are attending. No one is waiting. What is the problem to attend? Any idea?
So I'm facing to join, like link sharing and sign in with the team, Microsoft Team account.
Actually, previously they were joining on the Zoom link, so it was easy for them. This is the first time they are joining with the Microsoft, so they are facing problem regarding the joining.
Yeah, but if you don't have the Teams application, you can choose either to join through the browser or to join through the
Yes.
the application?
Yeah, I mean, I tried. It was the first time I had to download the software. First, register for your webinar, then download that application, then register for that, and then I could join the meeting. So it was a long procedure, like 10, 15 minutes for that.
Oh, okay. I think maybe next time we can do like we can join earlier before the meeting, so this technical issue will be fixed.
Or if we are gonna do it on Teams, we can tell them before. I think that
Yes,
this
yes.
would be the
Yeah, you're right. So we reached to the left ventricle volume changes during the cardiac cycle. And as we see here, these are the different cardiac cycle. And here, the isovolumetric contraction phase, as you see, there is no change in the volume inside the left ventricle. And when you start the phase of the systolic ejection phase, because the aortic valve started opening at this point, so the volume inside the left ventricle or the blood inside the left ventricle will be ejected to the aorta, and you will notice that the ventricle, the volume inside the left ventricle will decrease gradually till it reach to this point, which is the left ventricle end systolic volume. And after that, the aortic valve at this point will start the closure. And at the same time, because the mitral valve is still closed, during the isovolumetric relaxation phase, you will notice that there is no change in the volume inside the left ventricle because the aortic valve is closed and the mitral valve is still closed. At the end of this phase, the mitral valve will start opening and the left ventricle volume will be increased because this is the initiation of the left ventricle diastolic filling phase. So in the isovolumetric contraction and the isovolumetric relaxation phase, there is no change in the volume. But in the ejection systolic phase, you will notice that the volume inside the left ventricle will markedly drop till it reach here at the end of the systole, which is called end systolic volume. And in the beginning of the diastolic filling phase, the left ventricle volume will start to increase till it reach to the maximum here, which is the end diastolic volume. And so this is the end diastolic volume, which is the biggest amount of the blood volume inside the left ventricle at the end of the diastole. And this is the end systolic volume, which is the minimum, the least blood volume inside the left ventricle at the end of the systole. The difference between the end diastolic volume and the end systolic volume, this difference is equal to the stroke volume that will be ejected by the heart with each cardiac cycle. And this is the left ventricle pressure time graph, and this is the left ventricle volume time graph throughout the cardiac cycle. And if you merged both graphs at the same time, so you can get the graph of the left ventricle pressure volume loop. So starting from this point, which is the point of closure of the mitral valve, which will start the first phase of the cardiac cycle, which is the isovolumetric contraction phase. And as you see that during the isovolumetric contraction phase, there is no change in the volume inside the left ventricle. So the volume inside the left ventricle will be the same, but you'll notice that the pressure increase from this point till this point because the left ventricle is contracting while the mitral and aortic valve are closed. So the pressure inside the left ventricle will reach to this point. After this point, the aortic valve will start the opening, and you will notice that there is increase in the pressure inside the left ventricle till it reach to the peak systolic pressure here at this point. And this is the ejection systolic blood. And as you see at this point, the volume inside the left ventricle was here at this point. It's almost 120 ml. With the ejection systolic phase, you will notice that there is reduction of the volume inside the left ventricle at the end of the ejection systolic phase. So there will be change of the volume from this point inside the left ventricle, from this point till this point. So at this point, this is the end diastolic volume, the volume inside the left ventricle at the end of the diastole, and this is the end systolic volume during at the end of the ejection systolic phase. And the difference between the end diastolic volume and the end systolic volume is equal to the stroke volume. And after that, when the aortic valve at this point will start the closure, so there will be no change in the volume because it will initiate the isovolumetric relaxation phase. So there will be drop inside the left ventricle pressure. The pressure will drop from this point till this point, which will lead to reduction of the left ventricle pressure without change in the volume. And at this point, again, the mitral valve will start opening. Opening of the mitral valve will initiate the left ventricle diastolic filling phase. And you will notice that the left ventricle volume will increase from this point till this point. So the left ventricle will start the filling from from the opening of the mitral valve till the closure of the mitral valve. So this phase is equal to the left ventricle diastolic phase, and this phase is the isovolumetric relaxation phase, and this is the ejection systolic phase, and this is the isovolumetric diastolic phase. So as you see here, all the 4 phases of the cardiac cycle can be noticed here during the pressure volume diagram. And all the phases of the cardiac cycle is being demonstrated here. This is the diastolic filling phase, isovolumetric contraction phase, systolic ejection phase, and isovolumetric relaxation phase. And as you see, at each point here, there will be opening or closure of the aortic and the mitral valve. Here, the mitral valve will start the closure. Here, the aortic valve will start the opening. Here, the aortic valve will start the closure. And here, the mitral valve will start the opening in order to initiate the diastolic filling phase. And if you notice here, there is 2 very important point, working point to the heart. This point is the working point during the diastole, and this is the working point of the heart during the systole. This point is called end diastolic pressure volume relationship, which is mainly is a surrogate for the preload of the heart or the filling status of the heart. And this point is called the end systolic pressure volume relationship. It describes the relationship between the left ventricle pressure and the left ventricle volume during the systolic phase. And it reflects the ejection, the cardiac function of the heart, which is called the ejection fraction of the heart, and also it is a surrogate of the afterload of the heart. So if this point has been changed to this direction, that means the preload state of the heart has been increased, and this happens if the patient is having diastolic dysfunction. So the preload state of the left ventricle will be increased, and this might lead to pulmonary edema for the patient. And if this point has been increased upward, that means the afterload status of the heart has been increased, so it might affect the performance of the left ventricle, and it might lead to reduction of the stroke volume that should be ejected by the heart. So increasing the preload and or increasing the afterload will lead to consequences of the performance of the heart. Increasing the preload state of the heart, it will cause a stretch or dilatation of the left ventricle, and it will cause back pressure and might lead to, at the end, with pulmonary edema. and increasing the afterload, it will a force that work against the heart during the ejection of the blood. So it will decrease the stroke volume that will be ejected by the heart, and this will decrease the cardiac output and might lead to hemodynamic abnormality. And if we look to the left ventricle pressure volume loops during the cardiogenic shock, so this is the left ventricle pressure volume loops in the steady state of normal heart. And this patient is having acute myocardial infarction. This patient is having a cardiogenic shock in advanced stage. And as you see here, in acute myocardial infarction, the working point during the diastole was not changed here, which is called the end diastolic pressure volume relationship. That means the preload state of this patient is still preserved. But as you see here, there is a drop of the cardiac function. The end systolic pressure volume relationship or the working point of the heart during the systole has been decreased from this point till this point, which means that the cardiac function has been decreased, which is you notice here that the difference between this point and this point is equal to the stroke volume. So the stroke volume has been decreased from this point to this point. That means that the cardiac function or the ejection fraction of the heart has been decreased. And this will happen in the acute myocardial infarction. So what will happen in acute myocardial infarction? The working point of the heart during the systole, it will be decreased, and the ejection fraction and the stroke volume that being ejected by the heart will be decreased, but the working point of the heart during the diastole is still preserved. But if the condition of the patient is still progressive and the patient progressed to the cardiogenic shock, so you will notice that both the preload and the afterload has been increased to this patient, and also the cardiac function has been decreased to this patient. So here, this is the baseline of the patient, the preload state has been shifted to this phase. That means the left ventricle end diastolic volume has been increased for this patient, which might lead to increase the incidence of the pulmonary edema in this patient. And this is the point of the heart during working heart during the systole. It has been reduced from this point to this point in the advanced phases of the cardiogenic shock. So you will notice that the ejection fraction on the stroke volume has been markedly reduced, and also the preload status of the patient has been depressed, and the preload of this patient is increased markedly. So this patient easily can develop pulmonary edema, and also because the stroke volume ejected by the heart decreased, so this patient will have hemodynamic compromise like severe hypotension and cardiogenic shock. And also these are the left ventricle pressure volume loops in those patients with heart failure. So this is the working point of the heart during the systole. In acute heart failure, it is decreased to this point, and in the chronic heart failure, decreased to this point. And also this is the working point during the diastole, which is a surrogate of the preload. Here, for the normal patient, it is at this point. In the acute heart failure, it has been shifted to the right, and in advanced heart failure, it has been shifted to the right more and more. So this patient is having drop of the cardiac function, and also have increased preload, which might lead to like flashes of pulmonary edema and pulmonary congestion. And as we see here, this is a patient with increased preload state. This patient is having diastolic dysfunction, and his systolic function is preserved. If you compared the blue graph with the green dotted one, you will notice that the working point of the heart during the systole is the same, but the working point of the heart during the diastole has been shifted to the right. That means that the preload state of the patient has been increased, and this patient might have flash pulmonary edema at any time. And here, this is left ventricle pressure volume loop for a patient with increased afterload. You will notice that here, in both graphs, the working point of the heart during the diastole is the same. It has not been changed. But as you see here, this is the working point of the heart during the systole. And this one also during the systole in the first graph and the second graph. But because the afterload has been increased, so this point has been shifted upward, and this leads to reduction of the stroke volume. This is the first graph, the stroke volume. As you see here, it is normal stroke volume, but when you increase the afterload, which will make forces that will work against the heart during the systole, so this will decrease the stroke volume inside that should be ejected by the left ventricle. So increasing the afterload will decrease the cardiac performance by decreasing the stroke volume. Going to the next phase, which is very important section in this lecture, which is the coronary perfusion. As we see that the heart is divided into two parts, the right ventricle and the left ventricle, and each part is perfused with coronary blood supply. And the right ventricle perfusion, it is happening during the systolic and the diastolic phase. So the right ventricle perfusion is happening during the systolic and the diastolic phase, and the left ventricle perfusion is mainly happening during the diastolic phase. And as you see here, this is the coronary blood flow against the time throughout the cardiac cycle. So this is the phase of the systole, and this is the phase of the diastole. And as you see here, during the systole, the left ventricle perfusion is very minimal. And during the diastolic phase, the left ventricle coronary perfusion is maximum. So what we see here during the left ventricle perfusion, it happened mainly during the diastolic phase. So if you want to increase the coronary perfusion for a patient through the intra-aortic balloon, so you should increase the diastolic time, the time for the diastole, and also you should increase the pressure during the diastole by augmentation of the blood pressure through the intra-aortic balloon. And regarding the right ventricle perfusion, as we see here, this is the systolic phase and this is the diastolic phase. You can see obviously here that the systolic perfusion and the diastolic perfusion are almost the same. So the right ventricle is mainly perfused throughout the cardiac cycle during the systolic and the diastolic phase. And if you plotted both graphs together with the coronary perfusion against the time throughout the cardiac cycle, you'll notice here the left ventricle coronary perfusion is mainly during the diastole, and the right ventricle perfusion is mainly during the systole and the diastole. And these are the changes of the left ventricle coronary perfusion during the phases of the cardiac cycle. So as you see here, this is the systolic phase and this is the diastolic phase. And as you see here, the coronary perfusion of the left ventricle is mainly happening during the diastolic phase. So this is the phase of the systole and this is the phase of the diastole. So the left ventricle coronary perfusion is happening mainly during the diastolic phase. And here, as you see here, during the systolic phase, there is minimum coronary perfusion of the left ventricle. So going back to the arterial waveform, and as we see that the arterial waveform is formed of starting from this point, okay, and this point will start the ejection of the blood, which is the ascending limb. It equal to the ejection systolic phase of the blood. And during the ejection systolic phase of the blood, you will reach to the peak of the pressure here, which is the peak systolic pressure. Then you will have the systolic decline. At this time, the aortic valve will start the closure. closure of the aortic valve will be noticed on the graph with the diacritic notch. And after the closure of the aortic valve, you will notice that the diastolic phase will start, and the area under curve after the diacritic notch is equal to the diastolic phase, and the area under curve before the diacritic notch is equal to the systolic phase. So the arterial waveform is divided into two phases. The first phase, which is the area under systolic phase, which happening before the diacritic notch, it is equal to the blood that has been ejected by the heart. It is a surrogate of the stroke volume of the heart. And after the diacritic notch, which is called the area under diastolic curve, which is mainly related to which is happening during the diastole, and this area is mainly a surrogate of the coronary perfusion. And as we see here, this is the arterial waveform, and this is the diacritic notch, and this is the area under systolic curve, which is called the systolic pressure time index, which is a surrogate of the stroke volume. And after the diacritic notch, you will find this area under the curve, which is the diastolic pressure time index, which is a surrogate of the coronary filling and coronary perfusion. And if you divided the ratio between the diastolic pressure time index over the systolic pressure time index, you will get what is called the subendocardial viability ratio. So the ratio here between this area under curve and this area under curve is called the subendocardial viability ratio. And this ratio, if it is high, that means the coronary perfusion for this patient is adequate. And if the ratio is low, that means the time for the diastolic pressure time index is low, and the coronary perfusion is suboptimal. And to understand this one, this is the arterial waveform, and this is the diacritic notch, and this area here is called the systolic pressure time index, which is a surrogate of the stroke volume. And this one, the diastolic pressure time index, which is a surrogate of the coronary perfusion. If you plotted these changes against the changes of the coronary perfusion throughout the cardiac cycle, you will notice here, if you notice this area is corresponding to the changes of the coronary blood flow. This is the coronary blood flow of the left ventricle, and these are the pressure changes with the arterial waveform. So this area is corresponding to the coronary perfusion during the diastole, and as you see here, the coronary perfusion is maximum in this phase, but here there is no minimum, there is minimum, or there is no coronary perfusion at this point. So if you are able to maximize the area under curve of the diastolic pressure time index, you will be able to increase the coronary blood flow to the heart. And this will be obvious here if you compare the normal graph for a patient who is known to be hypertensive and who is having heart failure. You will notice that in normal patient, the diastolic pressure time index and the graph of the coronary perfusion is higher than this patient with hypertensive disease and heart failure and is having aortic stiffness. As you see here, the area under curve for the diastolic pressure time index compared to this one, it's much less. And if you compare the coronary perfusion for this patient compared to this one, it's much less. So if the area under curve has been decreased, the coronary blood flow will be inverted. But if you increase the area under curve, the coronary perfusion will be increased consequently. And this what is happening during the intra-aortic balloon. So this is the arterial waveform, and this is the arterial waveform during the augmentation with the intra-aortic balloon. So this is the arterial waveform, this is the diacritic notch, and this is the diastolic pressure time index. This is the unassisted waveform, and here the intra-aortic balloon started working. And as you notice here, the intra-aortic balloon started the augmentation during the diastolic phase, which is called diastolic augmentation. And if you check the area under curve here, it's much higher than the area under curve here, which means that there is the increase of the area under curve, it will lead to increase of the coronary perfusion to this patient. Going to the next section of the lecture, which is the arterial ventricle. I know this section might be very difficult, but let's say that if we have the heart is contracting during the systole, that means it is ejecting the blood during the systole. Is it clear? Hello?
Yes, yes.
Okay, as you see that during the systolic phase, the blood will be only ejected to the distal organs during the systolic phase, right?
Yes, doctor.
So what will happen during the diastole? There is no blood going to the distal organs during the diastole, because during the diastole, the aortic valve is closed and there is no blood ejected by the heart to the distal organs. Is it logic?
Yes, but there are the
So,
peripheral organs that like
the,
contract and
okay,
relax, which is called a peripheral heart. So it helps to
how
like perfuse the blood
it work? You can
by
describe this?
by contracting the muscles and relaxing the muscles.
Um, let's
Oh,
make it more clear. During the ejection of the blood, during the
Yes.
systole, the blood will be ejected from the heart to the aorta, right?
Yeah. Yes.
After the end of the systole, the aortic valve will close and
Close. Yes.
no blood going from the heart to the organs.
Yes.
Okay, so you
Yes.
should notice that the blood flow should be intermittent, right?
Yes.
Because the blood will be directed to the aorta during the systole, and during the diastole there is no blood flow. So the blood flow should be intermittent, but this is not happening in the reality
Yeah.
because of the phenomena which is called the arterial Windkessel effect. The arterial Windkessel effect, it works because you know the arteries are elastic, right?
Yes. I know.
So that means it has the property of distensibility. Okay, so it can accommodate the pressure. Okay, and it can expand, right? Okay, is it clear?
Yes. Yes, doctor.
So the volume inside the blood vessels, it can be increased because it is stretchable and it has the characteristics of distensibility, right?
Yes. Yes.
This happened during the systole when the blood ejected from the left ventricle. Part of the blood ejected from the left ventricle will be directed to the distal organs, and the other part, it will cause expansion and distension of the aorta, right?
Yes.
Okay, and during the diastole, there is no blood ejected from the heart. Okay, so you will notice that there is a drop of the pressure inside the aorta.
Yes.
At the same time, the left ventricle, the arterial tree, it was distensible, it was dilated. So with the elastic recoil, the blood stored in the wall, it will be ejected to the peripheral organs. Is it clear? Let's make it more clear. So this is the heart.
Yes.
So this is the heart. The heart will start
Okay.
the contraction, and after that, the aortic valve will start opening. Then the blood inside the left ventricle will be ejected toward the aorta. And as you see, part of the blood will be directed to the distal organs, and the other part will cause distension of the aorta. This is supposed to be the aorta, the dotted, the white dashed line. This is supposed to be the baseline of the aorta. But after ejection of the blood from the left ventricle, the aorta will be distended from this point to this point, from this point to this point. This distension because part of the blood has been stored in the wall of the aorta. Okay,
Yes.
Okay. So
Understand.
going to the diastole, what will happen during the diastole is that the aortic valve will start the closure. There is no blood ejected by the heart to the aorta. But as you see, the aorta is still distended at this phase. So what will happen is that the elastic recoil will happen, and the blood that was stored inside the wall of the aorta will be directed to the periphery. Okay,
Yes.
that's why during the diastole you will find continuous blood flow to the distal organs. So the arterial Windkessel effect is able to make the aorta and the vasculature to make it like a second pump during the diastole. So the heart will work as a pump during the systole to eject the blood to the organs during the systole, but the aorta will work as a second pump by the elastic recoil to eject the blood to the distal organs during the diastole. So the arterial Windkessel effect is the ability of the cardiovascular system is to maintain continuous blood flow throughout the systolic and the diastolic cycle. Okay?
Doctor, I have one question.
Yeah.
Uh, and at which phase peripheral heart will act?
The
Peripheral
mean
heart.
the during the diastole.
Yes, there is diastole. What is the difference between like this one and the wing this wind castle effect of the arteries and the peripheries?
Okay. Let me show you that video. So you see here there is a heart, and here
Okay.
this is the aorta. Okay.
Okay. Okay.
The aorta normally it has the elastic criteria. That means it is able to
Yes.
stretch and
Yes.
able to have the criteria of the elastic recoil, right?
Yes. Yes.
Okay.
Yes.
So if you lost this criteria, that means your aorta became very stiff. What will
Okay.
happen? It will lose the stretchability and distensibility, right?
Okay.
So it will lose the arterial Windkessel effect. Just see
Okay.
this video and you will understand it. See? So here, this is the cardiovascular system, the aorta, but
Yes.
this part is stiff aorta without the elastic criteria. So the heart will start the contraction and will
Mhm.
start ejection of the blood during the systole and the diastole. Just notice the flow. What you see here, can you explain what you are seeing here during the systole and during the diastole?
Actually, video is not smoothly run, so it is difficult to.
Okay, just from the sound, you can see what, you can hear what, you can hear that during the contraction of the heart, you will find the blood going to the circulation during the systole, right?
Yes.
But
Yes.
when the heart stop the contraction, you will find that there is no blood going to the aorta or no blood going to the distal organs, right?
Yes.
So
Yes.
here, what happened here is that you are having intermittent flow, not continuous flow,
Yes.
right? Here
Yes.
again.
Mm-hmm.
So here only ejecting the blood to the distal organs during the systole, right?
Okay.
But
Yes.
during the diastole, there is no blood flow going to the organs, right?
Mhm. Yes.
So what will happen if you added the elastic part to the circulation?
Yes.
Here, they removed the stiff part of the aorta and they added the elastic part, okay, to the
Yes.
aorta. Just see the video and you will notice that the changes, okay?
Mm.
Very clear now, huh?
Yes.
So here the heart is working as the first pump during the systole. It is ejecting
Yeah.
the blood, and the
Yeah.
aorta is working as a second pump during the diastole.
Okay.
Is it clear?
Yes.
This is the arterial wind castle effect. Okay.
Okay.
So the arterial wind castle effect is able to perfuse the distal organs with blood flow during the diastole, right?
Okay.
So what will happen during the run out of the intra-aortic balloon? The balloon, as we know that it inflates during the diastole, right?
Yes.
So it will increase the perfusion to the organs, the brain and the heart and distal organs during the diastole. It is simulating and maximizing the arterial wind castle effect. Is it clear?
Yes.
So you are just increasing the blood flow to the distal organs because the inflation of the intra-aortic balloon during the diastole, it will cause displacement of the blood to the brain, to the heart, to the kidney, to the distal organs during
Okay.
the diastole. And this what the body is normally doing during the diastole.
Okay. So basically, when the balloon inflate, it basically help to increase the wind castle effect, right?
It simulate and maximize the wind castle effect because also
Yes.
during the diastole, the wind castle effect is happening even if there is intra-aortic balloon, right?
Yes. Yes.
So you are maximizing the you are simulating the wind
Yes.
castle effect, and also you are maximizing the wind castle effect because the wind castle effect is responsible for perfusion of the heart during the diastole. So the intra-aortic balloon is displacing the blood inside the aorta up and down in order to perfuse the aorta. Okay.
Okay, sir.
So going to the next part of the lecture, which is the mechanism of action of the intra-aortic balloon. So as we know that the intra-aortic balloon is designed to sit in the proximal part of the descending aorta. It should be distal to the left subclavian artery origin and should be above the renal arteries. And this is the safe area for displacement of the intra-aortic balloon. And the balloon is filled with the helium gas. And when the intra-aortic balloon is inflated, it should include 80 to 90% of the aortic diameter. And the balloon is only inflating during the diastole. And as we see here, this is the ECG, and this is the arterial waveform, and this is the balloon pressure waveform. And as we see here, this is the inflation point, and this is the deflation point, and this is the inflation timing for the intra-aortic balloon. And you see here the intra-aortic balloon starts the inflation during the diastole immediately after the diacrotic notch in order to maximize the area under curve of the diastole, which will, as we discussed in the coronary perfusion, which will increase the area under curve for the diastolic perfusion time index, which will increase the coronary perfusion. Okay. So the intra-aortic balloon is inflating in the diastole in order to augment the diastolic blood flow, which will increase the perfusion of the organs during the diastole for the brain, the upper limb, the coronary, and the distal organs also. This is happening during the diastole. And also when it inflates during the diastole, it will increase the coronary perfusion to the left ventricle and right ventricle. So the balloon inflates during the diastole and deflates during the systole. And this is how the intra-aortic balloon working. And as you see, when the balloon inflates during the diastole, it displaces the blood to the upper limb, to the cerebral circulation, and also the coronary circulation. And downward, it increases the blood flow going to the kidney and the distal organs. But when the intra-aortic balloon starts the deflation, this will make like a vacuum. This will create a negative pressure inside the left the aorta, and this will decrease the afterload during the systolic phase. So the balloon is helping the heart during the diastolic phase and also during the systolic phase. During the diastolic phase, it increases the diastolic area under curve, and it will increase the main arterial blood pressure, and also it will increase the coronary perfusion and distal organ perfusion. And during the systole, the balloon will start the deflation. This deflation will decrease the afterload against the failing heart. This reduction of the afterload, it will help the weak heart in order to eject more blood, and this will increase the stroke volume and the cardiac output. So this is the mechanism of action of the intra-aortic balloon. Any questions? Any question from your side?
No,
No,
doctor.
doctor. Thank you.
Okay, very good. So when the intra-aortic balloon starts the inflation, how it works? The intra-aortic balloon inflate during the diastole when the aortic valve closes. This is very important. Why we explore the cardiac cycle? Because if the intra-aortic balloon started inflation while the aortic valve is open, so this will make displacement of the blood inside the aorta. It will go back to the heart. This will not help the heart. So ideally, the intra-aortic balloon, it should inflate during the diastole, where at that time the aortic valve should be closed. Inflation of the intra-aortic balloon, it will cause displacement of the blood, which will increase the perfusion to the organs, and also it will increase the coronary perfusion. So the benefits of the intra-aortic balloon inflation during the diastole, it will increase the main arterial blood pressure, it will increase the coronary perfusion, and it will increase also the cerebral perfusion and other organ perfusions. Oh, and what will happen during the intra-aortic balloon deflation? Basically, the deflation, it happened during the systole. So this happened before the aortic valve opening. The intra-aortic balloon, when it starts deflation, this will lead to rapid decrease in the aortic pressure. And this rapid decrease in the aortic pressure, it will be beneficial in decreasing the afterload of the left ventricle. And if you decrease the afterload, so you will be able to decrease the workload of the heart. And also, as you see in this slide, that when you decrease the afterload, you will help the heart to eject more blood. So this will increase the stroke volume that should be ejected by the heart with each cardiac cycle. So you are able to decrease the afterload, decrease the workload of the heart, and increase the cardiac output and stroke volume during the deflation phase of the intra-aortic balloon. And regarding the IABP waveform, the terminology, as you see, this is the arterial waveform. The arterial waveform is formed of the anacrotic limb and dicrotic limb, and the point between the systole and the diastole is the dicrotic notch. So prior to the dicrotic notch, you will find the systolic phase, and after the dicrotic notch, you will find the diastolic phase. And the intra-aortic balloon, it starts the filling and augmentation at the dicrotic notch. So what will happen that the area under curve of the diastole, it will be maximized, and the area under curve of the systole, it will be the same. So the intra-aortic balloon will start inflation at the dicrotic notch. This will lead to augmentation of the diastolic pressure and increase the area of the undercurve of the diastole, which will increase the main arterial blood pressure and also will increase the coronary perfusion. And the terminology of the intra-aortic balloon, so this is the unassisted before the dicrotic notch, before the inflation of the balloon. It is called the unassisted form, and after the dichrotic notch and inflation of the intra-aortic balloon, it is called the assisted waveform. So this is the unassisted end. This is the unassisted end diastolic pressure, and this point is the peak systolic pressure, which is the unassisted systolic pressure, and this is the dichrotic notch, and this is the diastolic augmentation. And here, this is the assisted end diastolic pressure, and this is the assisted systolic pressure. As you see, the difference between the assisted systolic pressure and the unassisted systolic pressure is that when the intra-aortic balloon starts deflation, it will decrease both the assisted diastolic pressure and the assisted systolic pressure. So the normal morphology of the intra-aortic balloon waveform, you should have the assisted systolic pressure at lower level than the unassisted systolic pressure, because the intra-aortic balloon, when it starts the deflation, this will decrease the afterload, and also this will lead to reduction of the assisted systolic pressure, and also it will lead to reduction of the assisted diastolic pressure. So you should have the assisted diastolic pressure lower than the unassisted diastolic pressure, and the assisted systolic pressure, it should be at a lower level than the unassisted systolic pressure. Regarding the hemodynamic effect of the intra-aortic balloon, you will have many changes that happen with intra-aortic balloon. Changes in the systolic events, in the diastole, changes with the coronary blood flow, and the changes in the cerebral perfusion. I think we completed almost 1 hour and 20 minutes. You want to continue the lecture, or you can continue later on?
We can continue later on. It's because
okay, so we can stop here and we continue later on.
Yes, doctor.
Okay. Because the lecture is very long lecture, and
Yes.
it should be divided
It's
into
very informative.
2-3 parts. Yeah, thank you.
Thank you. And doctor, I have some question.
Okay.
Yes. You told that in arterial elasticence, when the afterload if increase, that leads to decrease the systolic volume, right?
If the afterload increased, this will
Yes.
decrease the stroke volume.
Yes. Stroke volume.
Yes.
Then how left ventricle distended, if like, because during if afterload increase, it usually it increase the left ventricle distension.
If the afterload increased,
just explain it. I have
if
some
the afterload
confusion.
increased, it might lead to left ventricle distension.
Yes.
Yeah, this happened because you have the heart, and you have the blood pressure inside the aorta. Okay.
Yes.
Right. In normal situations, the pressure inside the left ventricle is higher than the pressure in the aorta. Okay. If the heart is working properly, so the heart will be able to overcome the blood pressure inside the aorta, because the blood pressure inside the aorta, it works as a force working against the heart. Right?
Yes.
Right. So if the afterload increased, so and your heart is weak, so the dominant power here, it will be the afterload. Okay. And it will work as a force against the heart. So your heart basically should be able to overcome this power. But if the heart is weak, so it will not be able to push more blood to the aorta. Right?
Okay.
If the pressure,
like in a myocardial infarction situation, right? When the
like
systolic
myocardial infarction, like myocardial infarction and heart failure. So the cardiac function is impaired, but the afterload is very high. So the heart is trying to contract, but it is very weak in order to eject more blood against this high pressure inside the aorta. So you have to decrease the afterload, as you see here. See? if we remove the intra-aortic balloon here and we said that the afterload is increased, so the afterload will increase as a force against the weak heart. So what will happen is that the heart will start to contract to eject the blood, to the aorta. But because the afterload is high, okay, so this will lead to as a force working against the left ventricle. So the stroke volume that will be ejected by the left ventricle, it will be less. So yeah, on the long term, the reduction of the stroke volume inside the left ventricle that should be ejected by the left ventricle, this will lead to dilatation of the left ventricle if your afterload is still elevated. Okay?
Yes.
So the afterload will decrease the stroke volume that should be ejected by the heart. And because the stroke volume should be ejected fully, and a part of it ejected and the remaining stayed in the heart, this will lead to progressive distension of the left ventricle if your afterload is increased. So the intra-aortic balloon is able to decrease the afterload with the deflation. So reduction of the afterload with the deflation, this will help the heart in order to eject more blood. And that's why they are putting intra-aortic balloon with this patient in VA ECMO in order to decrease the afterload, and this might help the left ventricle to eject more blood to the aorta. Okay?
Okay.
Any more questions?
I think one has.
There is no questions in the chat. No questions.
Actually, I am right now busy with the patient over here in Mubarak Hospital. So we are doing we are doing the positioning of the patient in Mubarak Hospital right now. But thank you
Positioning.
so much. Yeah, I mean
Yeah.
so this is a wonderful presentation. I mean, I learned new things.
I know the physiological part might be difficult for you, especially the cardiac cycle. It's very, very difficult. But you have to know the cardiac cycle because the problem with the timing, it might affect the performance of the intra-aortic balloon. Instead of being helpful to the heart, it might harm the heart, especially if you are having like early inflation, late inflation, early deflation, late deflation, because this timing, the intra-aortic balloon will inflate and deflate in improper timing, because it might inflate while the aortic valve is still open. So it will increase the afterload, it will increase the workload of the heart. So instead of being helpful to the heart, it might harm the heart. So you have to know the cardiac cycle. But I know this part is very difficult, even for the doctors. So I know that the first part of the lecture is very difficult, but starting from the coronary perfusion onward, I think it's much easier. And I hope that you understood the arterial wind castle effect.
Yes, doctor.
It's much clear now, right?
Yes, it's now very clear for me.
Yeah.
Thank you for explaining.
Yeah, thank you.
Oh, yes. Don't cover this metal rim part of it where we can see that. Yeah.
I think they are managing the patient in Mubarak, right?
Yes. Sorry for that. Actually, the thing I just want to add is the one that Vikas was talking about, the peripheral pump, is while we do the exercise and then our, I think the lower legs actually, they do it. They act as a pump as well, a secondary pump. So that's what I think. The phenomenon that Vikas was mentioning at that time, the peripheral heart, the peripheral pump, that's, I think, related to the skeletal muscle contractions that act as a secondary to the circulation, to the heart circulation. So
I'm not sure of this, but it is related to the the characteristics of the cardiovascular system of the blood vessel.
No, not exactly that. It's only a skeletal muscle activity which actually aids the circulatory system. That's
Yes,
only
because
that's
this.
only through exercise.
Yes,
Then also,
yes, but this is called a peripheral heart when the skeletal muscles of your legs like contract and relax, and it helps. I think related to mostly it's related to a preload effect because it helps to
Yeah.
return
It's
blood.
not related to the afterload. It's not related to the
Yes,
blood ejected by the heart. It is
yes, it's
related
blood.
to
Yes,
the
it's related to
venous
preload.
return. It is
Yes,
related
it
to the venous return.
exactly.
Yeah.
yes, exactly,
Because
exactly.
this will only maximize the venous return to the heart,
Yes, yes,
especially
yes,
during the vigorous muscular exercise, because you need more venous return. Because
yes,
during the vigorous muscular exercise, the body is
yes,
increasing the cardiac output, and to match the balance between the venous return, because ideally the venous return should be
yes,
equal to the cardiac output. Okay, so what's
yes,
going inside the heart is equal to what's going outside the heart. So
yes,
during the vigorous muscular exercise, you
yes.
need more blood supply to the muscles, and when the muscle is squeezed, it will increase the venous return
Mhm.
to the IVC and to the heart. So this should achieve the balance,
Yes,
but it's not related to the wind castle effect.
yes, it's not. When Kessel effect is a different thing.
Yes, it's mainly related to the arterial circulation, because
Yes,
the purpose of the wind castle effect is to maintain the perfusion of the organs during the systole
mhm.
and the diastole, and this happen only on the arterial side.
Yes,
Okay.
yes, sir.
Okay, thank you. We will
Thank you.
arrange for another meeting inshallah next week.
Inshallah. Thank you,
Okay.
doctor. Thank you so much.
Okay, thank you. Bye bye.